Good afternoon, everybody. It's really a pleasure to be here and to talk about one key issue that is really important for me. So, we'll be talking about some challenges in Central and Eastern Europe, and we'll be focusing on transmission and acquired resistance, and we'll be focusing on a special population. So, regarding this presentation, I have no conflict of interest. And we will be talking about an overview of HIV resistance data. What are the available data for 2020? Then we will be focusing on special population, as the title of the presentation was already emphasizing. I am a Romanian physician, of course, my special population will be the Romanian experience of long-term survivors. And we'll be looking at some data. And again, we will finish by getting back to resistance, transmitted or acquired. So what do we mean by resistance to antiretrovirals? And what is the idea of the resistance and especially the clinical outcomes of that? We know that we want to have a successful treatment for our patients. And when we talk about heart, we need to have it as robust as we can in order to do not jeopardize our drug resistance. So we can either have a resistance that is present at the time of transmission, so-called transmitted resistance, or we will have a resistance that evolved during treatment with multiple antiretrovirals. And that is due to the fact that we will not achieve complete suppression with the HIV replication. So the successful of the treatment will depend on the sensitivity of the HIV to the drug in the treatment regimen, and we can do that by doing the baseline resistance that will underline any transmitted resistance. And that baseline resistance can have an worsen of the outcome, but that resistance testing will really help improve the outcome. So I made a few cartoons downstairs where you can see the resistance over here, which can be either transmitted or acquired. And we will be focusing on this nice special population because the impact of resistance is really important on special ones. So what will be the evolution of the HIV drug resistant mutation during the treatment? It may be driven by several causes, like suboptimal adherence that we already talked about, drug-drug interactions that we know that can affect the level of the antiretrovirals, the high baseline HIV viral load and the low CD4 count, which we know that are two parameters that are really important to measure and keep an eye on it, and the use of antiretroviral regimens that do not exhibit adequate activity against our HIV strain. So we do need to choose the right treatment at the beginning and think about all of that in order to rule out resistance. But resistance can happen. And we have the recommendations. This is really an old slide, so to say, from the beginning of the EX recommendation that we will say that when we want to overcome the resistance, we really need to use at least 2 or 3 active drugs in a new regimen when we change the regimen. Because we talk about resistance, we cannot talk about resistance from the point of view of the treatment. So we need to keep an eye on that or whenever we will do the switching for this kind of patients. This is a slide from an article that was published a few years ago in 2012, but it's a nice gathering of the authors from the Balkan area, from our area, virologists, top virologists that looked about the HIV molecular epidemiology in the Balkans. And they called it a melting pot of high genetic diversity. Us as human beings are diverse and also the virus. So you can see over here the strains of the virus that are really a little bit special in the area. And as I told you that I am a Romanian physician, you can see that Romania is special from the point of view of the strains. So we have subtype F that we may have an impact on resistance and also on our long-term survivors, the population that we'll be focusing. So we do know that we have the resistance that is common against antiretroviral treatment experienced patients. There are some recent studies that will say that around 78% of the antiretroviral treatment treated individuals will have a phenotypic resistance to antiretrovirals. 51 of them will have resistance to two or more antiretroviral classes, and 40% will have a triple class resistance, which is quite a high number. So what we can gain from this study is that we will have a pool of patients hard to treat in the near future with resistance to even three classes of antiretrovirals. So there are some other studies done a few years ago that underline that we have a resistance in newly diagnosed untreated patients, so that transmitted resistance that we talked about, around 40.5%. So we do have guidelines, European guidelines, EACS, the US guidelines, DHHS and ES guidelines that will say that we do recommend testing for resistance prior to selecting the antiretrovirals for acute infections, chronic infections, and treatment failure. So nowadays, we do have the recommendation to test for resistance. This is another article that was published last year and will underline what will be the prevalence of resistance in the area where I am from. So the European area, the central southeast part of Europe. Otherwise called. So over here you can see that it was identified a resistance of 10.7 for Hungary, Serbia around 9%. When we talk about Croatia, less than 22%. When we talk about Greece, 19.6%, and the resistance that was identified for Romania of less than 10%, for Bulgaria around 5%. So we do have identified resistance in patients that are under our care. And these are really recent data published last year. There are a few areas for which we do not know the exact prevalence of resistance. This is another nice study that these are unpublished data nowadays. It was given to me by my colleagues in the lab. So we talk about transmission of HIV drug resistance and the predicted effect on current first-line regimen in Europe. How will this change our way of thinking when we look at our patients? And these are a few data that are extracted from their for that unpublished data that I want to focus around. So transmitted drug resistance in Europe is around 8.2%. And if we will focus for Romania, it's around 4.7%. And mainly the transmitted resistance is responsible for NRTIs. And you can see over here the graphs comparing different years of transmissions. So they were gathered by groups of years. The last years, we seem to have a drop in the overall resistance, but the trends are similar for all three categories, NRTIs, NNRTIs, and PIs. On the other hand, when we looked at the last year data regarding transmission and what will be the main mutation that we'll have to think about it and identify for the NNRTIs, for example, you can see over here that we talk about the more frequent mutations, the ones that we are expected to see in a population that was treated and that will come into contact. So last year, we haven't identified any transmitted drug resistance for integrase inhibitor in the newly diagnosed patients that were tested. On the other hand, when we looked at the pool of data in our lab, and we looked at newly diagnosed and also biological failure, a few more with biological failure, we identified one or more mutations, major mutation in 70 patients, two or more mutation in 26, and again 3 or more mutation in only 11 patients. I didn't do the percentage because they are not relevant, but if we think that each of these numbers are really patients for which we have to identify and clarify a way to treat them, it will get more important. So looking at the Stanford resistance database for which we pull the data, and looking at what will be the most frequent mutation identified for integrase inhibitors, you can see that N155H was the most frequent identified, that we know that is a non-polymorphic mutation that is selected in patients that will receive integrase inhibitors like tegravir, elvitegravir, and rarely for dolutegravir patients, and it's associated with high level reductions as a susceptibility for altegravir or elvitegravir, and it caused a low level reductions in dolutegravir susceptibility. So it's one important mutation. Looking at other mutations, here I only want to emphasize that this mutation that will go in combination, the 140 will go with the 148, and the effect that will have on integrase inhibitors, you can see underlined in the slides, but we need to look at this mutation in combination, and we really need to see their impact on the so-called second-class integrase inhibitors like dolutegravir and tegravir. If we want to say something about E138K, which again is a non-polymorphic mutation that is selected in patients receiving raltegravir, abiraterone, and even dolutegravir, we know that this really occurs in combination with Q148 mutation, and alone they do not reduce the susceptibility of integrase inhibitors. However, they occur in combination with Q148 mutation. They are associated with a high level resistance to raltegravir and elvitegravir, and also with some intermediate reductions of dolutegravir and tegravir susceptibility. So these are some important cases, and in the case that this will arise, we need to think about double dosing, for example, for dolutegravir. Again, combination of the pathway that we'll know that will go, as I already mentioned, E138K plus 14H. So we need to think about these mutations that will arise together, and you need to think of the impact that will have on susceptibility for older integrase inhibitors and but also for the new ones. On the other hand, this is just a few data that were presented last year at our National Congress in Romania, when we again look at newly diagnosed patients to see what will be the mutation. I will not talk about the whole slide. I want to emphasize that there are patients in which we do not identify any transmitted mutation, either for NNRTIs and NRTIs. And when we looked and when we switched for protease inhibitors, we can say that there are some mutations that are transmitted. Again, we need to think about the history of each country, the history of the patient in the country, and how will that impact the long term. So the conclusion of our batch resistance mutation and looking at this number was that we should consider this mutation that are both highly sensitive and specific indicators of transmitted drug resistance. Look and ensure that we talk to our virologists in the lab and see the impact of that mutation on resistance, on the patterns. And then we need to talk about population-based surveillance of transmitted resistance that we need to uncover and develop. Of course, we know that COVID changed our whole view of what's going on. So SARS-CoV-2 infections literally took over our labs, and now we are focusing more on that infections. But our HIV-infected patients getting back to them and the resistance pattern, we'll need to look at them more deeply in the near future. So the special population I want to emphasize is this Romanian population that we called young by age because they were infected in the early childhood, as you can see over here, and now they reach a median age of around 27. So they are young by age, old by treatment, because they have been exposed to a lot of antiretroviral treatment, and they have aged with HIV. This is why it's really important to focus on this special population that now have migrated to all the countries in the Europe. So we do have a rise of hope because when we look at this 2020 view of the HIV, the pipelines, we will have some options for these challenging patients, but we need to look at that resistance daily in order to identify what can be an options for them. Of course, the new patterns, the new drugs, we really play an important role in the near future. So to sum up, we do have to think about resistance. We do have to think about the transmitted resistance. And I hope that I raised your attention regarding what will be the most important thing that we need to rule out when we talk about a patient. We need to gather up all the information that we have for our patients because all the exposures to their antiretroviral will have an impact of the strains of the virus that we have nowadays. So we need to pull up the available treatment that we have for them and look for new options, as I already tell you. And when we gather the two of them, the transmitted resistance and the acquired resistance, we do have to think of the patient because we talk about the virus, but we talk about a patient with a viral infection. So we need to have options for them and we need to look at further options for this kind of patients. And ending up, I really like these slides because it applies to what's going on. Now our resources in getting all the lab tests as quick and as quick as possible for our HIV infected patient has a little bit of a delay. But even if we do have all the resources, it's really important how we can use them. So even in the COVID area, so to say, we need to look at our patients and try to pull out the available data that we have, look at the history of the resistance regarding acquired resistance for our patients, and test the resistance for the new patients in order to link that special population to the care. Thank you.